Hello.
Hello, just wanted to do a quick sound check if we can. So Sherri and Shannon, are you both on and able to hear me?
Yeah, Sharon.
Sharon, I'm sorry.
Sherri, yeah, Sherri and Sharon.
Sherri and Sharon, yes. Sorry about that.
Now, am I showing my desktop or is this somebody,
This
not
is
me.
mine.
Okay, so I just need to say next or?
Yeah, give it just a minute. So I'll take this one down and then you
Oh.
can share your screen and show your slide deck unless you've already got a starter slide. This was more just as other people.
Oh, perfect.
The 10 o'clock hour was a breakout session. We had people go to two different kind of Zoom rooms. So we're going to give it just a minute and they can trickle back in. And so often good so that they know what session they're coming back and joining. So that makes sense?
Yes, it does.
Hey, Sharon. Hey, Sherri. How are you?
Good. How are you?
Good. How are you?
Good. Thank you so much for joining us. It's really awesome.
Happy to help.
Yeah, we're just one big global healthcare IT community right now, right?
Exactly.
Oh my goodness. Yes.
Yeah.
Absolutely.
Now, are the other presenters, do you want us on video along with our presentation or what have you been doing?
Well, I know that the other presentations, they have kept the video on, so it's much more, I guess, real.
Yeah, that's fine.
So,
I just wanted to, yeah, that's perfect.
So, yeah, that'll be great. And, it's, so I know one of you is in Colorado and one of you is in Minnesota, correct?
That is correct.
Yeah, that's awesome.
Well, no, you're not in Colorado. She's in Arizona.
Oh, that's right. Wait, I thought you said, I was looking at how to share my screen. So
Yes, I'm in Minneapolis and she is in Phoenix.
Yeah. Sorry, I was thinking about Sarah.
And Sarah's in Colorado.
Yeah, I know. That's what was going through my mind. So thanks to her.
Tell me. Okay, so what do you guys see? Do you see my?
Yep.
We do. That's great.
So I want to minimize this. Okay, so now you can see the beginning page.
We sure do.
And me.
Yep.
Okay.
Yep.
I just wanted to make sure.
I'm going to turn off my camera so that I'm not a distraction. And Ajay, it looks like we are right at the top of the hour. So I will turn this over to you and our guest today to take it from here.
Great. Well, thank you so much, everybody, for joining. So this is, again, some great sessions and another great session from two very experienced healthcare IT professionals, and wanted to start off by introducing them. So hopefully everybody's had some great experience so far last week during our day one, and again this morning. We've had some great speakers. So let me start off and I'll introduce our speakers for today for the Memoirs of a CNIO During a Pandemic. So firstly, let me introduce Sharon Kirby. She is the Chief Nursing Informatics Officer, the CNIO for Mayo Clinic, a great institution. She is a registered nurse with over 15 years of healthcare experience in a wide variety of specialty areas, and over 10 years in nursing informatics and executive leadership. Sharon's responsibilities include providing strategic vision leadership for the Mayo Clinic informatics team across the enterprise and advancing the utilization of clinical information systems and data consistent with the goals and objectives of the organization. By the way, you should watch that Netflix documentary about Mayo Clinic. It's an awesome thing. Anybody in healthcare should be watching that. She is a collaborative executive leader passionate about creating and implementing strategic data-driven IT programs that improve business operations, patient safety and quality, and bottom line profits. She is a member of HIMSS Executive Institute and a Minnesota HIMSS board member. Yay! And she holds a Master of Science degree in nursing with an informatics specialization and is ANCC board certified in nursing informatics. So welcome, Sharon. And next also is Sherri Hess. She is the Chief Nursing Informatics Officer at Banner Health, and she has over 30 years in healthcare experience with the past 20 years as a healthcare IT leader. She serves as a strategic liaison between clinical leaders and IT. She does this by addressing the information and knowledge needs of healthcare professionals and patients to promote safe, effective, efficient use of health IT in clinical setting. Sherri role models change management and evidence-based practice in all strategies, and the patient as the focus. She also serves on the Colorado HIMSS board for 9 years, and also as president. And the Colorado chapter received the chapter of the year. So great job. That's awesome. I know how difficult that is. That's not easy. She served 2 years on the HIMSS nominating committee. She is an adjunct professor at the University of Denver and a Nightingale luminary and also a HIMSS fellow. So great credentials, great background, both of you. And Sherri, I will give you the ball and way to go. Good luck. Break a leg.
Thanks. Sharon and I are very excited to be here with you all today. While you can see us, we can't see you. But please, as you have questions, please let us know. As we start this, we want this to be interactive, and we have a lot of time probably towards the end, and would love to hear from the rest of you also. While we can share some of ours, we would really encourage you all to also provide input and feedback on some of the things you've either seen or would like to have seen as we are getting into the second part of this pandemic we're not out of yet. I think we're all aware of what HIMSS is as a global advisor and leader.
Thank you, Sherri. So hello, everyone, and great introduction, Sherri. Definitely want this to be interactive for all of you. But of course, we have our obligatory learning objectives to describe the informatics role in a pandemic, and definitely would like to hear others' stories of how you've navigated the pandemic as well. Discuss the similarities and differences between two large healthcare organizations in response to COVID, explain the role of technology in the pandemic, and identify lessons learned from the pandemic.
Great. So for those of you who may not be aware of who Banner Health is, we recently, as of last month and this month, have grown. We were a 28 hospital system, now 30. We just, Wyoming Medical Center in Casper recently became part of the Banner Health family. And on Monday, while many of you may have had other things on your mind that was been happening this week, we opened a new hospital in the Southeast Valley called Banner Ocotillo, a community hospital, and opened that with a lot of new technology. So I've been spending my days and evenings as we opened that. And actually our first baby that was born there, the midwife didn't make it in time and the nurse delivered the baby. So it was great to be there as part of that opening. But we also have University of Arizona in Tucson is part of ours. And we're throughout 6 states, critical access hospitals, pretty much an accountable care organization. I also have our Banner Health Network. We are the largest employer in Arizona and employ over 50,000. That number, not sure now that we've added the 2 where it is, but we've continued to grow. So a lot of great things that Banner is doing. And really our slogan is, we do want to make healthcare easier so life can be better.
Thank you, Sherri. And Mayo Clinic, many of you may know of, but we have a large pool of very talented employees, over 65,000. Approximately 14,000 are registered nurses. And we span Rochester. Our main destination medical center is in Rochester, but we're also located in Phoenix and Scottsdale, Arizona, and Jacksonville, Florida, as well as throughout the Midwest in Wisconsin and Minnesota, which is called Mayo Clinic Health System. And most recently, we are now in London, and also this year opened in Abu Dhabi. So definitely have a global reach as well. We do see about 1.3 million patients a year from 138 countries. So definitely see a wide range of the population. And I think what's interesting to know is, patients tend to come to Mayo Clinic after they may have been diagnosed or weren't able to be diagnosed. And we do find that 88% of the patients that come to Mayo either receive a different diagnosis or what they would call a refinement of their diagnosis. So definitely incredible organization and work that we do.
Great. So imagine, imagine that Lauren, on her day off from caring for patients at Banner Health University Hospital in Phoenix, and actually on the COVID-19 unit, she went to the Arizona State Capitol to meet those protesters that were protesting the stay-at-home order that happened earlier this year. She stood in silent protest. As she said, people approached her enraged. They didn't believe she was a nurse. Some were even carrying rifles. She understood their anger, saying we were not there to discredit their suffering, but really we saw them as our patients. She wanted to be there as a voice for healthcare workers. We wanted to be heard and seen louder than a lot of the misinformation and the fear that has sort of been the sweeping across the nation, and with this movement to open too soon. Nurses are scared to watch their states open. And as they are treating some of the sickest patients they've ever cared for in their life, we've had nurses say they can't go back to where they were. They have a lot of PTSD. Imagine that you're at that bedside and the family members aren't able to be there, and you may be holding an iPad and doing a video chat so the family can at least be there, but you're the one time and time again who's holding that patient, crying at their side as they're passing away with no family members. As I stated, as you're aware, Banner is in 6 states, and here in Arizona, we weren't part of the earlier response, as many of you know. We were hit a little bit later. Colorado was hit earlier in the mid-March and April timeframe, and really improving in May. So as a system, we came together. And then in Arizona, we hit later. We closed too late. We opened too soon. But we were more prepared as a health system. We started increasing our numbers here in Arizona in late May, with our peak in July and August is when we improved. We were at one time, we were the hot spot in the whole world. And Arizona, I think, still is the only state, while health systems have done this, that implemented crisis care as a state. Meaning, if we needed to look at rationing, if you will, care, who gets what, equipment, staff, etc. Well, we know as healthcare workers, those things are discussed often. We came together as a state to do that.
Yes, so here at Mayo Clinic, our surge, I will say, was different than some of the other organizations here in Rochester, Minnesota. saw very little COVID, more in the cities in Minneapolis and St. Paul. They were surging more, not so much us in the Midwest. But because we have campuses in Arizona and Florida, we were seeing surges there, and did share nurses with some of those sites. Even in Abu Dhabi, we sent a plane full of nurses out to Abu Dhabi in support of the pandemic. So there is a lot of advantages, of course, to being in a large organization, but we had to swiftly move, as everyone did in the country and the world. And for an organization like Mayo Clinic, that's 150 years old, and I do, as AJ pointed out, do try to watch the Netflix series on Mayo Clinic. It's quite fascinating. And with that as a backdrop, incredible amount of history and tradition in the organization, and always strive for perfection. The bar is very high here, and we really had to shift to it may be good enough. Perfect, we don't want perfect to be the enemy of good. And how can we really be more nimble? And so we quickly moved to reprioritize a lot of our projects. We put 400 to 600 projects went on hold, and we only kept about 20 still up and running that we felt were essential. 60,000 of our employees in 5 states and 3 time zones, we had to quickly move them to teleworking. So that's about a third of our employees were transitioned to home in 6 days, which is phenomenal work by our IT department. We had to revamp our clinical workflows, of course, and the informatics team were highly involved in that, and then shifting to a lot more home visits. In the midst of all of that, as you all know, early in the pandemic, hospitals were asked to cancel elective surgeries and other non-essential types of visits. So with that, of course, there was a lot of financial ramifications. So in the middle of trying to navigate all of this work and prioritize things, we also had to look at how were we going to furlough 40% of some of our departments. And my department was one where we had to furlough or reduce hours, but still ensure that we were keeping the right people that had the right experience on the books, so that we could keep focused on the work that we had ahead of us. And so we tried to pull away from normal operations and really just focus on what we needed for COVID change requests in the EHR, and then anything related to patient safety, regulatory, financial.
Great. And at Banner, very similar to what Sharon experienced in March. It seems like it was the week maybe National HIMSS was supposed to happen. We also went from working either at a corporate office and to working at home, still at home, and don't even know when we'll go back. Well, I do spend time at some of our hospitals, but overall we were told, be at home. So same type of thing as Sharon experienced and at Mayo. From a financial perspective, what we were asked to do was from at the corporate level, if you were in a leadership position, senior director above, we took pay cuts for a few months. I think it was 2 months. And then our staff was asked to do a 2-week furlough. But during that time, they could either use their PTO or they could take it without pay. It was totally up to them. We wanted to ensure, and many others, what we were able to do, let's say, as Sharon spoke about, as we stopped surgeries, right? Any of the scheduled surgeries, the non-essential, we repurposed many of those staff to either, we upskilled thousands of nurses that maybe hadn't worked in an ICU or med-surg area. So those peri-op nurses, our education team really got in motion, put together an upskilling for them, and was able to put folks into those positions. We also brought in 1,000 nurses. When we then ramped up again, we brought in 1,000 not just nurses, some RTs, providers to help during our surge. That was really bad. That's a lot just here in Arizona, if you can imagine 1,000. Now, we didn't have to open any tent type or another hospital. We were looking at one that had closed, the state had, because we did, being a large organization, we had some areas that were, I'll just call empty, right? Some floors, we had built some new towers that we were going to repurpose. We were able to put patients in there. So we didn't have to go to the outdoor opportunity there. Really got creative and that, but as one of our physician leaders said, we were one nursing home outbreak from having 0 beds. So what I thought was pretty amazing from a Banner perspective, as I stated, is we had that surge in the northern Colorado area as a system. One thing Banner does really well is the leaders come together, as many of the organizations you're at, and really put a great plan together. And we did also send some nurses from the Arizona area up to work in our northern Colorado area, and then even vice versa as they helped that. But our staff has really felt the leadership at Banner. Our CEO began very quickly, starting with emails, video messages. The staff felt very connected as my boss, Dr. Holland, and our chief clinical officer, Dr. Bessel, did go out rounding. At one point, they wanted to talk to staff. And what they, were hearing was how they, while this has been very tough, they felt from a leadership perspective, we were always put them first, which is where it says keep employees safe and save as many lives as possible. That's what we've stuck to. Really took out, you never heard any leader saying anything from a finance perspective. We've got to take care of our employees, and we followed the CDC guidelines. And so our rate of COVID from a staff perspective was really low and still below what the national average is. And then our chief clinical officer, as I said, Dr. Bessel, which under her, is also safety, quality, regulatory, and that's what my boss, Dr. Holland, he leads that, and really looked at ensuring that part of that really spoke a lot about that safety and quality and made sure that the staff knew that was the focus. She also met on a regular basis with our governor. That's when he allowed it. Not so much anymore. He's done meeting. And she also brought, we came together as all the health systems. So the CMOs, the physician leaders met, and the nursing leaders on a regular basis from a statewide perspective, and also would help work with the leadership here in our state to provide the direction on where we should be going. We also, that I thought was very important, was our executive team and the board knew that we needed to adjust our annual initiatives. And that was to really focus around COVID. And to me, that really spoke to the leaders that came to the table and knew what was important to focus on. So around our PPE, right? Retention, keeping our staff safe. So they really felt as though, and to now, we just had our voice employee survey. So it'll be interesting to see during these times, we had moved it, what the response is going to be from that, senior leadership really being involved.
Yeah, Sherri, we had weekly video chats with our CEO, Dr. Ferrugia, and then there was an opportunity for Q&A that people could submit questions ahead of time. It was called Glad You Asked, and they're still going on, but they really were beneficial for staff to hear, right from the top what we were doing, really being empathetic to what people were going through, because as you all know, when you're working in healthcare and you're in a crisis like this, you're professionally stressed, but then everyone has been personally stressed as well. And so those sessions are very supportive to the organization. So we are, can you go to the next slide, please? We are currently, our state of surge right now, we are surging now in Minnesota and Wisconsin. So right now, Eau Claire, Wisconsin is really hard hit, and in Rochester. And so we're seeing a lot of community spread. It's affecting our, some staff because, they're getting subjected to it in the community, and then it affects our staffing. And so we've had to be really creative in making sure that we're using all of our resources to the best of our ability. But because this is sort of wave 2 of the surge, in our first surge, it really started to become apparent to the organization the importance of the informaticists. And I say that because although we're always there, informaticists, I always like to say we're a supporting role, and we don't we're not always out in front, but you need them in the background. And with the first wave of the surge, we were not getting pulled in early enough, and people were going in many different directions and getting down so far in a road, and then realizing that they couldn't go any further. They didn't have what they needed, or they didn't have the information that they needed. And so it quickly became apparent that if the work was going to get done and done quickly and done right, that they had to bring an informaticist in from the beginning, so that they could, when they're putting in these change requests for the analysts, et cetera, that they're very robust requests at the front end, so that everyone else could expeditiously do their work. And so I would say that I've heard from many CNIOs that they saw similar things at their organizations, that it's really highlighted what an informaticist value, what they bring to the organization. We also, all of our sites stood up incident command centers. We actually had to stand them up again now in the Midwest because they had stood down. Informaticists participate in those command centers as well. We were the ones that created all of the COVID workflows for the organization and the screening processes. We, at that time, had done about 60 or so facility bill changes in our EHR that allowed for the surge, the building of departments for our overflow patients for surging. And then we actually became part of the labor pool, which we're starting to do again now in the Midwest. Swabbing or screening, or whatever the organization is asking us to do. Most of my team are registered nurses. I do have some that have clinical backgrounds but are not registered nurses. But we have been asked, to participate as well. And at times like this, it's all hands on deck, right? Taking care of the patient is the most important thing. We worked closely with nursing education and our EPIC training team as far as helping to create curriculum for those nurses that we were taking from the ambulatory space to inpatient, or from the surgical areas to inpatient to support. So a lot of just-in-time training for those individuals. And then we also, I'll show you a screenshot on our next slide of navigators that we created. In the ED, we created pandemic navigators, and then for inpatient disaster navigators. I just got word today that the incident command centers are the ones that can really pull that lever and say, yes, we're going to use these navigators, sort of shorthand for, in the event that there is a crisis. I just heard that they are implementing those in Wisconsin today. So, and we have those built and in production. They're always there. They're always an option. So once they get approval to use them, then we have that in place for the nurses. The reporting, as you all know, I'm sure you've experienced much of the same. There was a lot of infectious disease reporting and dashboards that need to be created. We had a big role in that as well. If you can go to the next slide, Sherri, there's just a quick screenshot of, it's really busy, but the pandemic navigator there for the ED up in the left-hand corner. And then on the right side is the providers and the nursing navigators is there below.
That's great. Great stuff, Sharon. And it's very similar at Banner. One of the things we'll probably, I do have simulation is underneath of me, and they were also part of the onboarding of those 1,000 and upskilling. We did set up the largest testing center for COVID, our ambulatory site sit, and we were at the fairgrounds. So a lot of folks were involved in there. But as Sharon said, we're here for all. And so we also just jumped right in to help wherever we were needed. So I probably didn't have any different. Now, the one thing I will say is this year we had in our budget, we were supposed to go live at 3 sites with CareWare Connect, which is mobile phones, the Zebra TC52, along with Cerner's CareWare Connect product, and put smartphones into not only our clinicians' hands, but all the teams at 3 of our hospitals. But due to the pandemic and resources being pushed everywhere, we still went live, as opened a new hospital, like I said, on Monday. And everyone at that site had a smartphone in their hand, even the security guard. So amazing stuff we can still do, even though we have a pandemic going on. So as Sharon was talking a bit about what they did, we also had created our disaster documentation and utilized, as I reached out to the other CNIOs across the US, really utilized what we were seeing from others on what can we do to decrease their documentation burden. And what I did was I put an interdisciplinary team of nurse leaders, nurses, our safety, quality, regulatory, as we reviewed those national standards. We put a policy together by April. Now, what we did a little different than Sharon did is we didn't necessarily change, and we didn't have that pandemic, but they have guidelines on what it is that they need to be documenting on. And we saw some that implemented, and actually I got a call that Northern Colorado is in process of implementing it again up there. And we may get to that. So depending on your mix at your sites on your unit, where normally, let's say you have, as a acute care nurse, 5 patients and, a shared tech. Well, let's say now that that number could grow, right? Maybe you have 6 or maybe not a tech. So we need to give them the ability, and actually our regulatory bodies also recognize that. So with that, we worked on what needed to be documented and what didn't. And we saw, you can see from here, some trends of where their time, if we just compared earlier in the year to now, while in some places it went up, think about the complexity of these patients. It really was, overall went down, and got great feedback. Now, you'll talk to some nurses and it's really hard for us to give up no, I have to document that. Well, but I really should, be at the bedside. So it was, using that critical thinking of what they needed to and what they didn't need to document. So one of the things that we did, we'll talk a little bit about some telehealth. We did have an ambulatory, what we put in place, I should say, is an ambulatory platform for e-visits. So you can see there in March, there were 0. And as we were able to quickly scale up, we have a CEO of our telehealth program and have been a leader for many years. I think, I don't remember how many now, but even have won some awards in our telehealth, but we hadn't had it, of course, in the ambulatory platform. It's being utilized still to this day by over 440 clinics, as you can see. And when I went to make an appointment just for my annual physical, I had the ability when I was going to schedule whether I wanted to be a telehealth or an in-person. So we're still continuing that. As you can see, there's a good place for that, and we'll see it kind of level off, but we've had over 56,000, the statistics probably higher now, but we've had a lot of visits. And we also looked at the visitors, their experience. So we asked for their feedback. 4.8 6 out of 5, and even the providers felt that it was a great opportunity. Then from an acute care platform, what we did was we actually scaled this up rapidly too in the acute area across all of our hospitals. And as you can see, 853 rooms to reduce that provider exposure and preserve our PPE. So you can see here from the pictures of a bit about what we did. That provider would be out in the unit, but would be having that conversation with the patient and the nurse through the platform that we put out there. You can see here even the totals of final room. Our goal is over 1,100. And our CEO of that telehealth platform, while we put some initial things in place, this isn't necessarily what we're going to say is our go forward strategy. So he's now creating, now that we were able to get this really installed and people really like it, what we want to do now is look at some more mobile telehealth platforms and endpoints throughout the organization.
Yes, so at Mayo Clinic earlier in 2020, before the pandemic really hit everyone, we were standing up our 2030 strategic plan around Cure, Connect, and Transform. And interesting enough, much of what is in that plan around the Connect part, at least, is really leveraging technology. And so we now look back and say we've actually implemented much of our 2030 strategy. So we were fortunate. We have an arm of Mayo Clinic called Connected Care, and they've much of the work that they've been doing is around video visits and remote patient monitoring and such. It was not a booming business, I'll say, because reimbursement was not there. Regulatory, many of the regulatory restrictions around that, and as you all know, they were lifted. Much different now. The approach to telehealth is much different now than it was then. But because we already had this infrastructure, we were able to quickly scale up this virtual care that we started using. One of the things that we actually worked with Epic on, we're partners with them on the building of these interactive care plans. And what we did was quickly create a COVID interactive care plan. And it's essentially, it's the ability to use a checklist type of interaction with the patient and through their portal. If a patient was a COVID patient, but considered not complex, but more not, what's the word? I'm sorry. If not a complex patient, then they were entered into this 21-day program. If they were more complex, they would be in the remote patient monitoring program, which is about 30 days. They'd be admitted to that. And then we also did our telehealth visits, of course. They used to be about 35 a day we were doing before COVID, and now well over 3,000 a day. So I know throughout the country, people were seeing the visits really ramp up. And then our one project that was continued and was not on hold was the what is called our Advanced Care at Home project. So this was slated to go live in Florida July 1st, and Wisconsin August 1st. And because of the pandemic, and because it gives us an ability to actually potentially a patient that is in the ER, we can transfer them back home, and it's an acute care in an acute care type setting, and provide all of the care in the patient's home, and sending care providers and such there to the home and monitoring the patients. And so we were successful in standing that up in those two states. And I can tell you now, Wisconsin, we're very grateful that we have that program because we're at capacity, and it's really been helpful to have this model.
Yeah, and that's great, Sharon, what you guys have done there, because we've even been looking at the model that you guys have put into place, and I've heard some great things about that. we're calling ours COVID at home, and did start that also. We have not seen as many, and that's accelerated. So do you want to do, we have the first one, did like intermittent vitals, where the patient would put on the pulse oximeter, do their blood pressure, etc. And then you have the continuous monitoring, where you can have a wearable. And it seems like that should be pretty quick and easy to do, right? But the model of how you and who, so from a provider perspective, who's going to be the one monitoring those patients? How's that information, getting to the physician, etc. So I haven't been involved in that as recently, but still looking, I'm sure as many others have been doing, on how to keep those patients that are kind of borderline at home, and how to get those that, well, we could discharge them today, but maybe we should give them one more day. That's where we were really looking at both those aspects, even prior to COVID, on how we could do that to, improve that throughput or keep them in the best place possible. I think it's really exciting, and as kind of we get towards our wrapping up, and really want to hear from all of you the great things that you've been doing, or questions that you have for Sharon and I. We would be remiss if we didn't talk about 2020 being the year of the nurse. And actually, I heard a fellow CNIO say a few weeks ago, I really think this is the decade of the nurse. This has been, an amazing year, a year unlike we've had. And not only the nurse, but of course, all of the care team. And for those of you who may not know, that is Florence Nightingale on the right-hand side of the slide. So are there questions? I know Sharon and I have, a lot of different things that we could share, but really wanted to take time for this to also be interactive and hear from you all, and either questions or things you're doing. And I can't see if there's questions because
I don't see anything in the chat. No.
Okay. I'll share as people are thinking about this. And when I was out rounding, when things got to a point where, we weren't completely full, I was on one of our COVID units, and I noticed baby monitors, and you've probably maybe all heard some stories of that. And we're like, well, what's that? See, and this is where nurses can be very clever and innovative. So, they found when they were in the COVID rooms, the best way to communicate, you need to keep the door closed. They're all, all their PPE on. So they did find some baby monitors, weren't very expensive. They could set outside the door. Between ours, there was actually a place to sit between every 2 rooms, so they could communicate during that time, and probably still have that up, right? You just come up with whatever it is that you need. There were so many things being requested that they couldn't wait for a corporate solution, and they needed it now, so they just went out and did it themselves.
Yeah, exactly. We did some similar things with iPads, of course, and it was part of our connected care strategy. We were using them for other things, but they came in very handy. We could mobilize the ability to use them. We're also doing some creative modes of care models, and we have a model, EICU is what it's called, and it's basically, providers that can visit ICU patients from Rochester, and they can see our other sites. Now we've used that model for nursing, and so we may have nurses in Rochester that can help troubleshoot or help mentor new nurses that may have a patient load, and we can monitor patients from Rochester to other places in the Midwest. So that has also been very beneficial. We do have a question, Sherri. Let's see. Looking into your crystal ball, what do you see as the future for your organization? So
You wanna go?
I can go
Yeah.
first just because I've seen it. So I already had a chance to think about this, and I'll give you a chance to think about it. Well, two big things are happening at Mayo. The idea of teleworking, as in many other organizations, this was not something that was broadly utilized in the past, and they are now definitely embracing the idea of teleworking, and that's been an interesting evolution to see how quickly this has come together. The other thing that I'm seeing is our delivery of care in the model I was just telling you about, EICU, that we're looking at the ability to really use that to extend Mayo Clinic's reach in many, many places, both with through our providers and nursing our Mayo knowledge. And so that's another exciting care model that I believe we'll probably see more of in the near future. Sherri?
Yeah, you know what? Sharon kind of took those are a couple of things I was thinking of. That Banner now really is priding themselves as called the employer of the future, even prior to the pandemic. And really from that perspective of we want to attract the best talent. So while some things maybe seem fairly simple, earlier in the year, I think it was this year, not last year, dress for your day. So while that may sound like, okay, can I wear jeans? So as a leader, as an executive, even our executives that sat up, they were on our 10th floor, and not all, but some, jeans. Now, even at our sites, now granted, not if you're a bedside nurse, right? There are certain, but they had to be professional looking. And while that may sound simple, we want to attract talent. Think about your IT pool, right? Many times they don't necessarily want to dress business casual. So we are looking into that. And then as Sharon was talking about the teleworking from wherever you are, we've shown it's been done. I personally do like to go into the office. I'm fairly close, while others aren't necessarily, and then spend my time at our clinics or urgent cares. So I think rethinking, right, about how and where our talent is. A lot of things around innovation. We have a Banner innovation group that is how do we deliver care differently? Actually, this group came together during the pandemic and got, I won't remember who it was, but reached out to different organizations, different businesses, in order to get masks made, right? In order to get hand sanitizer. I think it was the local brewery. I'm sure you all have seen some of those stories, but some of them were early on. Can we clean our PPE? Sorry, it's been like I said, opening a new hospital. I've been on site for 12, you know how we do that, multiple hours. So as the end of the week, I'm dragging a little bit. And I really think about how do we change our care, right? Utilizing that telehealth, keeping patients or our customers what's the right setting for them. It shouldn't always be within kind of that brick and mortar. We've got a great ambulatory site that we're creating in the West Valley that is really looking at some technology from utilizing, some of you may have heard it, Nuances Ambient, now I'm going to forget the name of it, where the provider's in the room with the patient and speaking, and while that's being picked up, they don't have to hand enter the orders, their notes are being put in. It's really trying to do those things. And really wanted to tell, and like I said, I'm not even sure who's on or what the background is. If there's even anything outside of the pandemic from a CNIO perspective or career perspective, Sharon and I are here to answer anything around that.
Sherri or Shannon, can I ask a question as well? So as the host, it doesn't give me the chance to put anything in the Q&A, so I get to do this live. You mentioned early on at the beginning of your presentation about coming together across regions on crisis standards of care. And that's no small feat, right? That's a huge undertaking, bringing together providers to align around, things like that, things like crisis standards of care or visitor restrictions, and trying to align some of those across regions locally or statewide. Can you describe a little bit on how you guys have had to partner or collaborate with other organizations to do that? And what kind of challenges or opportunities has that brought?
Yeah, so early on in this, and like I said, around Colorado being first, and thinking about what could this pandemic look like, and having some, visionary leaders, we sought out, we actually took Utah's crisis standards of care, and like I said, our chief clinical officer, Dr. Bessel, is just amazing, and really reached out to her colleagues and said, let's come together. Our CEO, our board members also reached out to the governor. His office would, have conversations really to help them understand, the science and what was happening within our hospitals, or could happen, right? We were starting to get those predictions coming up. So overall, from getting those providers together, even though we may be competitors, we're by no means seen as that anymore. And they would meet on a regular basis, even as I said, the CNO. I didn't hear any barriers that they had to that. From what I was informed from Dr. Bessel and Dr. Holland, is they were all open to that. Probably the biggest barrier has been more from the governor's office. And I'm not, but don't take it away. I'm trying to, negate that. I just think these are opportunities as health systems, and working with our public health, the physician who's over our public health, Dr. Kara, she, this is something that, well, even though that's what her specialty is, we'd never seen that. So let's come together. And there is still some meetings happening. They're doing tabletops around that on let's work through it. Our physician ethicist, we even did simulation trainings using the crisis standards of care on what does that look like. So my senior director over simulation actually went to a couple of our large sites and walked through. So they'd present, like, here's the case. And there were different, people played different roles. Not having been through that before, I learned quite a bit about it. But, you don't know the patient's name or who they are. You're just given some of the facts. And those who are caring for the patient aren't the ones making the decision. So as they walk through that, it really helped them feel more comfortable that if we did have to put that in place, that it wouldn't be so devastating, right? We don't go into this to make decisions like that. We go in there to save, as I'm sure, Sharon with Mayo being a health system that is, seeing patients that aren't necessarily given the best prognosis. But I would say if you don't have a crisis standards of care, look for one, and then also partner with your either state, which we did early on and got that approved prior to us having to use it, and then also with your other healthcare leaders, and just continue to meet and take out that competitiveness.
Yep, completely agree. We did much the same here in Minnesota, for example. When the Twin Cities was really surging, we took a lot of the patients to Rochester. We diverted patients to them. And then being on the board of the Minnesota HIMSS, I was able to quickly reach out to other informatic leaders. And this is, for the most part, most of our healthcare systems in the Twin Cities are Epic shops. And so we were able to share information quickly. And then Sherri and I are on the Healthcare Academy that gives us a conduit to national reach with other CNIOs. And so we shared a lot of information that way as well. So that multiple ways that we were coming together. I'll say we have what we call ourselves One Mayo, even though we have campuses in multiple states and in other countries. But we did find that once we stood up our integrated EHR, which was a implementation over the last 3 years, we completed it about a year ago, actually. Prior to that, we were not on one EHR. We had a little bit of everything, it felt like. And so having that ability to quickly make changes that impacted all of our sites, that this EHR has meant that we could be much more nimble and have much more novel input than we ever could have if we were the way we were prior. We did discover too early on, with each site having their own incident command centers, they were starting to all go down their own road of what they were going to do and create. And so we ended up having one weekly call that everybody, all of the incident command centers had to call into, so that we could ensure that we were in unison in decisions that were being made. And then we have a very good process that we're able to expedite any changes that we're going to go in the EHR to make sure that we had input across the system.
Great. Any other questions?
Hi, this is Ajay. I don't know if you can hear me.
Yep.
So don't know if there's any other questions right now, but I don't know if you can see me. I think I have my video on, but
yes.
In any case, if nobody has any other questions, I wanted to thank both Sharon and Sherri. There I am. Sharon and Sherri for joining us today and agreeing to participate and support our chapter. It's always great to get information and input and things that experience from other parts of the country outside of here in Ohio. So we get that perspective. Some of the things that you've said sound very familiar to me, because us here in Cincinnati at UC Health, that's my employer. We've done some pretty similar things, if not the same, at our organization. So I think that's just been a trend. And but yeah, this is a unique year. We've had everything from a pandemic to murder hornets to an election. My goodness, I think hurricanes, you name it. I think everything in the kitchen sink has been thrown at us this 2020. But I think we're resilient, and I think it really says a lot about all of us that we've been able to go through this and more, with so much resilience. So thank you so much for both of you, for your contributions to healthcare IT, to your focus on better patient care through information technology. It's great. As a HIMSS fellow myself, I'm truly dedicated to that purpose. So thank you again for joining us today.
Thanks for having us.
Thank you.
Have a great
Appreciate
day.
the opportunity. Thank you.
Bye.
All righty, folks. Alex, back to you.
All right. Sharon and Sherri, thank you again so much. That was great. Learned a lot from how you guys are looking at this from a multi-state perspective. It's always interesting, and lessons learned from those. So thank you again.